Hi there, my name's Elisa McDougall, and I'm a registered nurse currently taking the Breastfeeding Experience Theory course. And today I've put together a video presentation where we address a breastfeeding challenge using a decision-making framework in order to guide our decision-making process. I hope that it's helpful and that you enjoy it. The breastfeeding challenge that I have chosen is hypoglycemia and a low milk supply. In this presentation, I will address both issues and how they relate to each other. In order to effectively help this mother and daughter, I'm going to use the situated clinical decision-making framework to help me make decisions. That includes knowledge, cues, judgment, decisions, and evaluation of outcomes. I will use this to make a nursing care plan. This breastfeeding challenge will center around Mary and Lily. Mary is a 23-year-old first-time mother, now 5 days postpartum with a healthy full-term infant named Lily. Lily was born via spontaneous vaginal delivery at 39 weeks with no complications. Mary had a very uneventful pregnancy with regular prenatal care. They were both discharged from the hospital 2 days after Lily was born. They were both healthy and had no complications. First, we meet Mary. She is following the advice of the nurses and breastfeeding Lily exclusively. She is now on day 5 and feeling completely overwhelmed. Her nipples are sore and cracked, and she sometimes delays feeds because of the pain of latching on. She states that Lily is constantly wanting to feed but then falling asleep at the breast. The nurse arrives for a well baby visit and finds Mary to be tearful. She says she does not have enough milk to feed Lily and her breasts are soft. She is unable to pump and she is only feeding Lily 4 to 5 times a day. We now meet Lily. The nurse weighs her and finds that she's losing weight from her discharge from the hospital. On interview, Mary notes that Lily has only had 4 to 5 wet diapers a day, and today as well as yesterday she is still having black tarry stools 5 days postpartum. The nurse then does a capillary blood glucose and finds that her sugar is only 2.1. In order to assist Mary and Lily through this breastfeeding challenge, we will apply the situated clinical decision-making framework. That begins with knowledge and knowing the self. I have both personal and professional nursing experience with hypoglycemic neonates and feel confident in my ability to instruct, assist, and educate Mary. I also have personal and professional experience in dealing with women with a low milk supply or a perceived low milk supply, and feel confident that I will also be able to help Mary and Lily through this challenge. Another important part of knowledge is understanding the case and the pathophysiology. In a term infant like Lily, hypoglycemia is a blood glucose concentration less than adequate to support neurologic, organ, and tissue function. In a neonate, it can cause poor feeding, lethargy, poor tone, jitteriness, cyanosis, seizures, and apnea. Hypoglycemia is caused by conditions or circumstances that lower the amount of glucose in the blood, that prevent or lessen the storage of glucose, or that use up the stores of glucose in the liver, or inhibit the body from being able to use glucose properly. Back to knowing the case, we know that Lily's feeding has been suboptimal, and this is likely the cause of her hypoglycemia. True low milk supply is actually quite rare, and most women are adequately able to feed their infants. However, we should explore causes of low milk supply in order to assist Mary with evidence-based knowledge. Insufficient glandular tissue or previous breast surgeries, mostly reductions, can cause issues with milk supply. Also hormonal or endocrine problems. Not feeding at night decreases the level of prolactin and lessens the amount of milk supply. Using hormonal birth control or other medications can also cause issues. Supplementation is an issue as well, as it decreases the need for supply and demand and decreases the amount of breast milk. This is also the same for pacifiers. Jaundice can also make a sleepy infant who doesn't feed as often. This decreases the amount of times the baby is eating. Therefore, removing milk from the breast is not happening as often, and supply and demand is decreased, and milk supply lessens. We must also incorporate a knowledge of the case into our decision making. We find that Mary does not feel she's producing an adequate milk supply and is feeling very frustrated. She also has very sore and cracked nipples, which is very painful to feed Lily. This is causing her to delay her feeds sometimes, and in the night, she is sleeping through some of her feeds. Lily often fusses at the breast and then falls asleep shortly after latching on. She is not adequately removing milk from the breast. She is only producing 4 to 5 wet diapers a day and still has black tarry stools, which is an indication that she is not receiving enough nutrition, in addition to the hypoglycemia and the weight loss. When we examine Mary, we find that she has no history of breast surgeries, no glandular problems, is not taking any medications, has no hormonal or endocrine issues. She is not supplementing Lily. We must examine Lily for jaundice to see if this is a factor, and we do find that she is using a pacifier. We must also look for cues in order to understand why this challenge is occurring. Many have already been identified in this case, but let's take a closer look at some of the cues that we've identified. We know from the blood glucose reading that Lily is hypoglycemic, but the strong cues as to why lead us to believe that she is inadequately feeding. Mary reports delaying feeds, only feeding 4 to 5 times daily when it should be a minimum of 8 times in 24 hours. Lily is not gaining weight. She is not producing enough wet diapers and is still having black tarry stools at day 5 post-delivery. She's also wanting to feed constantly and fussing at the breast, but falling asleep shortly thereafter, which is an indicator that she has given up and is not adequately removing milk from the breast. The next step is judgment, where we decide what we need to do about this and prioritize care. We have found that Lily is not receiving adequate nutrition and Mary is not feeding effectively. I have identified my 3 top priorities, which are to 1, correct Lily's hypoglycemia, increase her weight, and get her feeding more often and effectively. 2, to ensure Mary feels supported and assisted with her breastfeeding so it becomes effective and her supply increases. And 3 is to assist the dyad in successful breastfeeding exclusively. My first priority is to increase Lily's blood sugar through feeding. I want to get her immediately on the breast and assist Mary with her technique. I want to ensure a correct and deep latch and that she is intaking an adequate amount. I want 8 feedings in a 24-hour period and ensuring that we have at least 6 wet diapers daily with more than 3 stools. I will teach her of signs of effective feeding and support her with positioning, including the importance of skin-to-skin contact. In Mary, I'm looking for the onset of copious milk production, firm tugging sensation on her nipple as Lily sucks, but no pain. She may have uterine contractions, feel relaxed or drowsy while feeding, experience increased thirst, notice that her breasts soften or lighten after feeding, and milk ejection or letdown will send a feeling of warmth or a tingling sensation in the breast. She also may notice leaking of milk from the opposite breast. In Lily, we're looking for a latch without difficulty, 15 to 20 sucks or swallows at a time, audible swallowing. We want her to easily release from the breast at the end of feeding. We want her to look content after feeding and have at least 3 substantive bowel movements and 6 to 8 wet diapers every 24 hours. Put simply, my first priority is to feed Lily. I want to assist Mary with correct breastfeeding techniques, including correct latch and positioning. We want to get her nipples healed and provide feedback for effective feeding. I could set up a consultation with a lactation consultant for ongoing assistance and support, and also provide breastfeeding resources so that Mary has the best possible chance of exclusively breastfeeding Lily and her hypoglycemia being corrected. My next priority is to move the milk and assist Mary in breastfeeding. Ongoing support with a lactation consultant as well as nursing care, proper instruction, help her with pumping and hand expression to increase her supply post-feeds, ensuring a minimum of 8 feedings in 24 hours and on demand. She will increase her fluid intake and keep properly hydrated with proper and adequate nutrition in order to increase supply. I want to solidify this by assisting Mary and Lily as a dyad, building confidence, educating on signs of effective breastfeeding, providing resources and information as well as ongoing support, and reassuring Mary. After intervening, I need to evaluate the effectiveness of the outcome. Is Lily gaining weight? Was Mary able to continue breastfeeding exclusively? Was the supply increased? Was the hypoglycemia corrected? Is Mary healing well? And is she feeling confident and reassured in her ability? Do I need to consult anyone else? Does this need further involvement, or have I corrected the situation? After seeing a lactation consultant and several follow-up visits, we find that Mary and Lily are doing very well. Mary's milk supply has increased dramatically with regular feeds, and Lily is gaining weight, having plenty of wet diapers, no longer having black tarry stools, and has not been hypoglycemic. The dyad has been supported and now are effectively breastfeeding exclusively.